Let me first of all just thank everybody for being here and joining us in our second of an important series of discussions that we're having on civil litigation reform here in the great state of Georgia. I want to start by thanking Del Vecchio Finley for hosting us today. We appreciate not only you having us today, but appreciate what you and the team are doing in the healthcare space, and thank you for your many partnerships. Also want to thank Kaylee Noggle for helping moderate today's discussion and keeping us moving. We did that at our first meeting, and I thought it went very well, but I certainly appreciate Kaylee's great leadership in the state government, but also now as the head of Georgia Hospital Association. I want to thank the representatives of the Medical Association of Georgia for being here, as well as the Georgia Healthcare Association, and certainly a lot of other leaders in the healthcare space. Everyone participating in today's panel represents the everyday heroes who help Georgians during some of the most difficult times and experiences of their lives, and I'm just very grateful for all that you all have been doing on a daily basis. I know a lot of people told you that during the pandemic, and a lot of people talked about healthcare heroes, but we still know that's the case today, and we just want to thank you for that. I also want to thank a lot of great public servants that are here with us today. Our sidekick, our Insurance Commissioner, General John King, President Pro Tem Kennedy, Majority Leader Steve Gooch with us today. I haven't seen James Burchett. Is Burchett here? Senate Insurance and Labor Committee Chairman Larry Walker, who's with us again. Senate Judiciary Chairman Brian Strickland's with us again. House Judiciary Chairman Stan Gunner, who's with us today. Stan, glad to have you. House Insurance Committee Chairman Eddie Lumsden is with us, and many other distinguished members of the General Assembly that are with us today. And I hate to go to calling names, but I appreciate Chairman Hatchett being here. A lot of the Middle Georgia delegation, Representative Dickey, Ballard, Darlene Taylor, Representative Kemp, Mathis, Patty Stimson just came in. Patty, good to see you. Formerly Patty Bentley, that I always want to call you. Danny Mathis is with us. I think I saw Danny come in. Danny, good to see you. And the Dean of the Senate, Senator Ed Harbison from Columbus. Dean, thank you for being with us today, and I hope I didn't miss anybody else. Also just want to thank Lieutenant Governor Jones and Speaker Burns, who unfortunately couldn't be with us today, but they were at our first roundtable, and I just want to thank them both for their really commitment to being engaged on this issue. And I know if you heard their comments at our last roundtable, you know that that is the case, and just want to thank them for their participation, not only with the great membership that we have here, but just them personally, as we work to level the playing field for a lot of hardworking Georgians out there. I shared at our last listening session that these conversations, we're having these so that it will guide our next steps in a multi-stage approach to reform in our state. Healthcare obviously is one of those areas most impacted by civil litigation, and one that impacts every single Georgian. It shows up in our hospital bills and our doctor bills. It shows up in the offices of our family docs, and it shows up in our monthly healthcare insurance premiums. Working closely with Commissioner King and the General Assembly over the years, we've worked hard to bring those premiums down to connect Georgians with more healthcare coverage options. I'm really excited about the work that we've been able to do in the past. We now have 87% of Georgia counties that have 3 or more carriers, and when I first took office, no county in the state had more than 2. So we've made a lot of progress. I want to thank the General Assembly and also Commissioner King for their hard work on that. Also, premiums are down 11% statewide and 29% in rural areas around our state. We've also worked hard to grow our healthcare workforce through multiple loan repayment programs, investments in our new medical school facilities, and many other areas. And we had a workforce roundtable yesterday, and we'll have the Governor's Workforce Summit that is going on today and tomorrow. So we continue to work on that issue as well. So while we're proud of all the work that we have done, we also know that it is not enough and that we need to continue to do more. Costs are still rising for Georgia families, and some students question whether they should enter the medical field at all given the exorbitant cost associated with practicing medicine, let alone acquiring the education that is needed. At a time when our healthcare heroes more than ever, when we need our healthcare heroes more than ever, I'm certainly eager to hear about how civil litigation suits have impacted this industry in our state and suggestions on how we can begin to address the problem in a fair and balanced way, one that ultimately benefits the patients most of all. I made a promise to the people of this state when I first ran for governor to find innovative ways to increase quality, affordability, and access to health care. That is a promise that we continue to keep in mind as we did when we passed the Patients First Act in 2019. It's a promise we work to fulfill every year since, and it's a promise that we're keeping now with this discussion. So with that, I'm going to turn it over to Kaylee to guide our discussions, and I look forward to us hearing your input on this important issue. Kaylee?
Thank you, Governor Kemp, for convening this roundtable and for the opportunity to share our stories and our real-world experiences with all of you. Thank you also to our legislative partners and to our many healthcare providers that are joining us today and for participating. Across the healthcare continuum, from hospitals, physicians, and long-term care providers, Georgia's current healthcare liability laws contribute to higher costs, drawing scarce resources away from our patient care and our communities, negatively impact providers' ability to treat patients, and fundamentally endanger the existence of many healthcare facilities across our state. As you heard the governor say, his first roundtable a couple of weeks ago with small business owners who are dealing with civil litigation and risk management issues just as we are. There was extensive conversation about the policy issues that warrant further conversation, such as the concepts of anchoring, transparency and damages, third-party litigation funding, private equity, and false advertising, and so on. Though these issues reach us most often through medical malpractice claims instead of other types of civil litigation, we share in those same policy interests. But rather than repeat what you heard 2 weeks ago, what I hope you hear today from our participants is the real impact that our current legal environment is having on the patients and the communities that we all serve. We have a short window today to cover a lot of ground, so we won't do formal introductions around the table, but please just state your name and organization as I call upon you, and just remember, again, your mics are hot. So let's dive in. Our first question, the General Assembly has wrestled with how to expand access to health care for years, particularly in the state's rural areas. Do you think lawsuits against hospitals and doctors play into our challenges with healthcare access? And if so, how so? And I'm going to turn it over to our host today, Mr. Delvecchio Finley, to let him answer this first question.
Thank you so much, Kaylee. My name is Delvecchio Finley. I have the real privilege and honor of serving as the Georgia Market President for HM Health, which covers our HM Health Navicent, or Central and South Georgia market, as well as our Northwest and Southeast Alabama market up at Rome at HM Health Floyd. I really appreciate the opportunity to be a host, and thank you so much, Governor, for you and your team and all of our elected officials and other healthcare partners for being here. Haley, to get to your question, I think the answer is an unequivocal yes. I absolutely appreciate the remarks the Governor you made, and more so your actions to improve access to health care, to improve insurance coverage and ability for people to get great care. At the same time, I think that the healthcare litigation environment or climate that we face is sort of countering those efforts in some ways. What we are seeing, particularly we talked about in rural areas, to your point, Kaylee, I'm sorry, that at HM Health Navicent, we serve a predominantly rural community, and that means that whether it is with our employed docs who we employ in our medical group, or with the independent docs who we count on to really serve our hospitals, the exposure that they have to healthcare med-mal costs and premiums, as well as experiences, is really making it harder for us not only to retain those docs who will serve our communities and serve everyone in our community, providing great care, but also to then recruit the future. We are seeing that in our residency programs across the state, not just with us. Our OB, for example, OB programs, we've seen a 10% decline in residency applications, and among among other things. So it's not exclusively, obviously, the healthcare litigation climate, but it certainly exacerbates it, I think it's fair to say, and contributes to those workforce challenges that we're working so hard in partnership with you to address. So I think that's important. I think there's a burden that happens in terms of psychological and stress, psychological burden and stress that happens on our providers with the lengthiness of these trials in the field or the experience that they're having here, and certainly, like I said, cost. Whether they are, a lot of rural doctors, as you know, are independent, single practices or small practices, mid-sized, very few large practices, and at every point, those costs are really increasing, and they are hurting our ability to attract and retain docs, who then, by extension, are hurting our ability to sustain that access to our patients in the community.
Thank you.
Chairman, can I speak to that?
Sure, Chairman Walker, sure.
So I represent Senate District 20, Larry Walker. Larry Walker, Senate District 20. I represent 8 counties. I have 5 hospitals in my district, so predominantly a rural district. I've done some work with DCH and all on the infant and maternal mortality problem in Georgia, and I've learned that I think 69 counties, last statistic I heard, do not have an OBGYN. I was with one of my hospital administrators earlier this week, and they would like to, or they've been, looking at maybe trying to attract OBGYN, and one of the big barriers is the cost of liability insurance if they take that on. So it's a real issue everywhere, but particularly with OBGYNs, apparently it's a highly litigious area, and it's preventing some of our parts of our state from having the care that the moms and the babies need. So
I think that's right, Chairman Walker. I think what data we have would say that OBGYN is the number 1 litigated medical specialty in Georgia. Commissioner King?
Yeah, Kaylee, I can add to that. Of all the practices as we describe, as we examine the marketplace, OBGYN are the highest, the highest expense. A typical policy for 1 year for a brand new physician coming into this is $100,000. That's $100,000 out of their pocket. Imagine that on top of a student loan, medical school, trying to start a practice, getting a lease on an office. It's cost prohibitive. And so these young doctors are choosing to go to other states.
That's right. Derek, I think you guys have had some recent experience with that. Is that something you want to talk to the group about?
I will. So I'm Derek Bridger, Chief Financial Officer, Liberty Regional in Huntsville, Georgia. So we're one of 2 critical access hospitals that still provide OB services today. Due to recent litigation we've had to look at service lines, and of course OB is one of the first ones you look at, knowing the extraordinary cost of it. So we're losing about $2.4 million on OB services today. Of course, we still want to offer that service to the community, but as we're looking at ways to cut costs, that's one of them, and unfortunately it would cost access to care for OB in the area.
And so if you were to do that, push people to Savannah, Brunswick.
Yeah, and Wayne Memorial,
Wayne.
Savannah and Wayne.
How many OBGYNs do you have on staff right now?
We have a model of 4, but we had to basically contract with a hospitalist OBGYN group for 15 days a month at over $8,000 a day for those services.
Yeah.
Kaylee, I would add, we're experiencing the exact same thing here in Milledgeville. We had 3 independent OBGYNs 3 months ago, and as of the end of this month, we'll be down to 1. And we're facing the similar sort of challenges, as my colleague mentioned, for retaining services in that community.
I think that's probably a topic we'll come back to a couple times. As we talk about recruiting medical professionals, has Georgia's litigation climate made it difficult to attract that new talent? I know we've heard that from some physicians. Dr. Jansen, do you want to speak to that with your experiences?
Sure. Robert Jansen, I'm Chief Medical Officer at Grady. Just as a little bit of a background, I've also been in private practice, so I've seen it from that perspective, as well as president of a large medical group. there are two facets to this that I can see. One is, can you attract people even to the state anymore? And practices as well as large groups still now wrestle with whether people want to come here. Georgia is unfortunately now known as a place where malpractice is a big detractor. And so attracting people, even to places, in the city, becomes difficult. So just finding people who are willing to come to the state has been influenced by this environment. But the other aspect is, can you afford it if you can attract them? And, you've heard from the rural counties, but it also applies to places like Grady. Payer mix is what determines whether you have a viable practice or not. And if your payer mix is such that you don't have good reimbursement, and then your malpractice cost and other cost of practice is so high, you're not going to bring people. The city of Atlanta has a healthcare desert south of I-20, in large part driven by that. So not only can you get people to come, but then can you afford to have them if they do decide to come? And OB we've talked about, but there are other specialties as well, neurosurgery, et cetera. Places that have high specialty but also high risk are subject to this. The other thing that happens, if you've ever been subjected to a malpractice case, and somebody touched on it, I can't remember what it was, the mental stress that causes physicians cannot be underestimated. So if you go into an environment where you think you're going to be subjected to that, you're going to think long and hard before you subject yourself to that.
Dr. Ray, you're on faculty and experience a lot of students and residents throughout your other day job. Have you heard that kind of phenomenon about that decision-making process from your students?
Yeah, first, I'm Chad Ray. I'm an obstetrician gynecologist, so don't target me. But I'll say that my entire career has been spent in Augusta, Georgia, where I've seen dramatic changes over time due to many reasons. The workforce really being one that has been a huge issue because of the things like you've already described with the hospitals and the closure of those perinatal units to really save the rural hospitals. But we are definitely experiencing a new day as it relates to our students and residents. They are in tune to everything in a way that I never was. I'm not that old, but I will tell you that it's very different in how they engage with respect to health policy, advocacy, how in tune they are to things like malpractice and what it's like in the environment where they're going to go practice. And it's been, while we make all of these efforts, and the state's done a good job to help with, initiatives that would help us retain and, our learners that will become our future healthcare workforce. Those efforts definitely are undermined by something that is so onerous as you just described. Anybody who knows what a lawsuit is like, I'm a state employee. Luckily, I have not sat at that table. But the reality is I can't speak on what that's like, but I can speak to those folks who I've seen run into our practice because of that. They've left other practices, they've left other states that were in similar situations to then be in a practice where they would just save the deposition, save the chance that they would have to go through that. And with the respect to cost of medical school, costs of malpractice insurance, I have certainly seen folks who leave residency now and choose to not do OB, something that is part of their training, and they're doing gyne only. I feel like a dinosaur a lot in the environment that I'm in, but the reality is that as I transition to OB only in my practice, for every time somebody does what I'm doing, there is probably a dozen or more folks who are doing exactly the opposite, and I really do fear for our workforce.
Yeah. I think that workforce and attracting and retaining folks is really important, but I think one of the things we also hear is that for the physicians in the room, that it also changes the way you're practicing now. Dr. Cannon, you're an emergency department physician, is that correct? Is that something that you've experienced or can speak to?
It is. Brett Cannon, emergency medicine with Apollo D. And Dr. Jansen and Dr. Ray really set this question up very well in the sense that the physicians with whom I talk and interview 10 years ago might have asked one question regarding the mid-mile climate, now come in with specific questions. It's at the top of mind. They may even have specific cases that they may reference and ask about. So to the extent that it is a challenge to attract those physicians, to keep them, to maintain the ones that we've taught, to attract out of state, they come in with a certain disposition. And in years gone by, we would see new physicians, perhaps.
Dr. Keenan, I'm sorry, can you grab a mic? Thank you. They can't hear you.
Yes.
Thanks, sorry.
We would see new physicians perhaps order more tests and advance imaging and perhaps admit more, perhaps transfer more. And as time and experience continued, those habits would change. But now what we see is that instead of that experience altering ordering patterns and treatment patterns, it's defensive medicine and charting that create the need to what they call buffer chart or add to the decision-making or investigate every thought that one might have. And that absolutely increased cost, that increases the number of hospitalizations, the capacity that the hospitals have has been filled up and stressed by, again, a lot of that defensive medicine.
Dr. Saylor, we were talking a little bit about that before we started. Do you want to speak to that a little bit as well?
Yeah, a couple of things from what's already been stated. One, when we get to the rural primary care physicians, we have a medical school in Athens, and we have the primary care residents that are working through the hospital. And I actually spoke to a couple of them before coming up here. Their interest in rural medicine is not what it used to be, and this is one of the main reasons why. They want to be in an environment that's more where they have more of their colleagues and peers and collaboration and the opportunity to reach out to someone for help when they need help, rather than be somewhere where they're an hour and a half away from getting the kind of help they need, and then they're stuck with responsibility for a patient who has a really bad problem, and they may have to sit there and manage that patient for hours or days trying to transfer to another level of care, because we do have constant bed capacity issues that go on, especially in our tertiary and quaternary facilities where we want to send patients who need higher level of care. So, I think that's a big component. And, sadly, the rural component is also where some of our lower socioeconomic patients exist and where they're at. And so our most needy aren't getting what they need. As far as the other comments that were made, I kind of agree with everything everybody that they've said so far. And what was the exact question? Because I've got so much I want to say.
We'll keep going.
I've got so much I want to say here, but
we'll keep going, Bob. We'll let you go.
As it relates to like we're talking about, I think you and I talked beforehand a little bit. So patient, we have patients in the hospital, and we have patients that are trying to get to hospitals. We have patients in the hospital, and we have, I know at Piedmont Athens, I know Piedmont Atlanta's even more. Piedmont Athens, we probably turn down 100 to 150 transfers monthly, probably per month, trying to get patients in. And it's not because we don't want to take the patients or we can't take them or don't have the ability to provide the care. It's because we don't have the bed capacity. So when you get into bed capacity, you get into issues of why do you not have bed capacity? Because we're having a length of stays that may exceed a day or two than what really needs to. And why is that? It's because physicians, we have patients in-house and we want to let them go home and we think they can go home and we're pretty sure they're going to be fine, but let's keep them an extra day or two just to be 100% for sure. And that falls into the whole category that Dr. Cannon was just talking about, which is the defensive side of how practices are going on. And what that does is it impacts access to care. The other impact on access to care because of this is number of providers in the state. What are we, 38 or something, I think? Or we're low. We're not where we should be. I recently, in our practice, and I'm a vascular surgeon, we added 2 surgeons. It took 6 years. 6 years to add 2. Recruitment was very difficult. I think the comment was made about the education level of, coming in about where they're at. Georgia is a very, very favorable economic state. Thank you, Governor. So it's really, we're in a good spot. But from a litigation standpoint, people are scared of this. And some of the awards have been so outrageous that it's really fearful when they exceed a level of what your coverage is. So, those are issues that our younger physician colleagues are facing and fighting every day, and hopefully we can do something to try to address that.
Thank you. For those of you that are administrators or physicians and have had to consider how to change your operations or how you practice medicine or specialties, can you talk to us about what those changes have looked like? Dr. Judah, is that something you'd like to speak to?
Absolutely. I'm Joel Judah. I'm the managing partner for a 3-person GI group here in Macon. We're affiliated with Navicent, and just say thank you very much for having us. Appreciate our political leadership listening. That's encouraging to us as physicians. And also, I will say that if you've had a colonoscopy, please don't hold that gallon of prep against me today, okay? But
It's too late, Dr. G.
we get to everybody eventually. But I just want to briefly mention about access and how that plays a role in how we practice. I mean, I could talk about the GI shortage very well here in the middle of the state. We've got I've been here for 15 years almost. Came here out of fellowship and went to Macon here in 2010. And we're down to about a third, maybe a little over a third of the GIs we had in our region. And when I say our region now, I'm not just thinking about Macon, I'm thinking about Middle and South Georgia, this whole 75 corridor. And so as I sit here, and I'm 47, which I still think's pretty young, but I am the youngest. Another partner's 47 as well. We're the youngest GIs in this area, and we're pushing, well into the 50s. So of kind of a median age of GI docs in this area. So you look at the future and you're like, wow, that's not a good succession plan when we have that kind of median age. And it plays into how we practice, because you say, well, I've got to see more patients because we've got these hundreds of patients who are waiting. They're getting sicker. They're calling our referral coordinators every day saying, we're hurting. Why can't we get in? We've been to the ER 3 times. We need to see a specialist. The access plays a role in how, you double book your patients. You try to see how many can you get. It's not that you're trying to just see more patients. You're trying to get to the people who are hurting. And the tort environment makes it more challenging because people are getting to you because of the delay in care. They're sicker. They're frustrated. And then you finally have the opportunity to see them, and you're ordering, and now you've got to make sure you dot all your I's, cross all your T's, because God forbid you forget something, you're a target. And I was telling my wife the other day, I said, when I drive down 75 South and I see all the signs up in the morning, it's a reminder that I've got to practice perfect medicine. That even if there's a mistake that I can't account for, I'm going to be held personally responsible. And it's not just my LLC or my practice, or it's me personally that's on the line, my reputation, my assets. And so that makes me, to answer the question about my practice. So I did another fellowship in advanced endoscopy after GI. And this is kind of where we do more complex procedures. It's typically higher risk procedures. A good example is, let's say somebody's got a big polyp in their colon. And typically you could have surgically removed it. Well, now you're going to come to me for an endoscopic resection. The question I have to consider is, given there's an inherent higher risk of complication in that procedure, do I keep doing those? It's the right thing for patients. It's good for patients. But I know that one bad outcome can easily lead me to be served in a lawsuit. And as soon as I'm served, I've lost. The stress that was mentioned, it can't be understated. It stays with you all the time. It's at night. You think about it. It personally impacts you. It personally impacts your practice. And when you go through these things, absolutely, when somebody says they've got abdominal pain, you're going to order as many CTs as you need because you're trying to prevent that kind of thing from happening again.
Good points. Anybody, Mark, do you want to speak to this? You want to jump in?
How long do you want me to talk? Mark Baker with the Houston Clinic. We're an orthopedic group. And it's interesting listening to everyone. I can relate to everything you're saying because we deal with the same thing. Kayla, you asked, what have we done differently? In the past few years, if you have not invested into risk management and layers of risk within your company, that is one reason I've seen a lot of groups get into trouble, because they do not take the time to understand what is occurring from a legal standpoint. So we have really had to invest and take the time in risk management to help try to mitigate those issues. Being that we're in 4 states, we have a little bit of a different perspective as well. And I'm not conjecturing, I'll just state fact. So when we're doing our malpractice premiums every year, our physicians will always sign up for clinics in Alabama because the higher percent that you practice in Alabama is discounted versus practicing in Georgia. So, and that's fact. And so we can run those numbers.
And, and I think another piece that we really need to think about here and not underestimate, Dr. Jansen, you've mentioned it, you guys have mentioned it as well, is the fear. It's real. We're settling cases now that we used to not settle. And we would go to bat and we would go to court. But now we don't want to go to court anymore. But I think the issue is larger than just one area to look at through legal or not. It's a three-legged stool. It is the insurance companies, it is the provider, and it is the legal. It's not just one area. It's a three-legged stool. So I think getting into the data would be great to help come to a solution. But one of the biggest things we're doing right now is having to hammer in on risk management.
That's a good point. That's a great segue to our next question about those of you that have seen your med-mal insurance costs increase over the last few years, maybe how much, how quickly. Van, is that something you'd like to speak to?
Sure, glad to. Van Laskowski, CEO of Stevens County Hospital. We're in Toccoa, Georgia. We're a 96-bed hospital. I've been the CEO there since September of 2021. Between 2019 and 2021, we actually saw our med-mal increase in terms of premiums by 16%. Now, this is interesting, and I'm going to kind of shake up things here. From 2022 to 2024, we've seen our med-mal drop by 13%. Now, when I went through my first renewal in 2022 and asked the reason from our broker, the reason was because we as a hospital had to make the decision in 2021 to end labor and delivery services. The cost was so prohibitive to the organization as it was, and we found ourselves in a position where we were unable to recruit physicians for OBGYN and pediatrics to our hospital. The reason we kept hearing why physicians are uncomfortable moving to a hospital our size or on the larger size of small hospitals is that you're the only physician on call in that specialty at one time. The physicians that we have coming out of training right now are used to having backup from their peers, and you're trained in these large academic medical centers. That's not what we are. You're the doctor on call. And between the concern they have for patient care and the concern they have for litigation, especially in OBGYN, it's already been highlighted that that is the most highly litigious medical specialty in the state. We were unable to recruit physicians to that specialty, and we're going to have to staff it entirely with locum tenens, and it was untenable for the organization. Since we had to make that hard decision, we've seen our med-mal drop year after year, and the farther away we get from that service, our premiums continue to drop. And it speaks to that we're in such an environment where the legal climate is effectively financially incentivizing you from restricting healthcare access.
Can you give me those numbers again?
Yeah, our med-mal increased from 2019 to 2021 by 16%. From 2022 to 2024, it has declined by 13%. The reason being, from our broker, is that the farther you get away from L&D, the more those will continue to decline.
That's a great point.
I can add to that. From 21 to 22 for us, the year I came in, after 15 years of, the costs are adjusted in many ways when you look at how you build your ladder, if you will. Our retention, the level that we had to have, 15 years was flat. 21 to 22, it increased by 50%. 23 to 2024, 1 year, our premiums went up by 115%. 115%.
Let me add to also is, as Dr. Cannon talked about, doctors having to do defensive, in their insurance companies are hiring third-party companies to assess the need, and what they're doing is they're comparing Georgia with the states around us, and so they're declining the coverage, the insurance coverage, because they see that as medically unnecessary. But they don't realize that the dire spot where you are is that you're practicing medicine in a defensive manner because you're trying to not only take care of this patient, but also to protect yourself from litigation. That's a good point. And so this, as you said, three-legged stool, and it's all crashing around the doctor.
I was going to mention we had a 5-year projection, and we're in year 5. And I pulled up the data, and we're 100 this year. We were supposed to be it was 157% of where we were supposed to be. And so, I mean, it's a strong increase. We knew what we were supposed to pay in 24 when we got in 19 when we got the 5-year projection, and now we're at 157%.
There's another aspect of this that you mentioned it, but it's important. Not only are your premiums up, but your retention is up. So for an institution like Grady, we have a retention before we even get into our malpractice insurers. But the other thing, settling cases that you ordinarily would not settle is a significant thing because you are not willing to take the risk to litigate. So you're going to settle sometimes at a much higher rate than it's really, quote, should be settled. But you really have no choice because it becomes Russian roulette when you go to court now. And, you know, do you take the chance of going to trial, or do you go ahead and settle for something you think is probably higher than it should be, but it avoids that risk?
I think there's pretty good data that will show that the cost of those settlements over the last few years has gone up significantly. Scott or Trevor, do y'all want to jump in not just on the cost of your premiums, but also the availability to get insurance at all, and start talking about layers of insurance? You got many of you, Scott, some other of our larger hospitals are self-insured and putting their own money up, and then they have to go to excess lines markets, and that those are really starting to dry up a little bit.
That's exactly right, Kaylee. It's Trevor Newberry. I'm Assistant General Counsel at Pruitt Health. Thank you all for having us, by the way. But you're absolutely right. Much like me when I was 16, we are virtually uninsurable at this point. And, you know, the fact is because we are, as they pointed out over here very astutely, we're left with no choice on these cases. The risk of going to trial is simply so high that it becomes existential for a given facility. And when you're talking about a facility in a rural area like Fitzgerald or Sylvester, where it's the only facility for, 100 miles in any direction, you're talking about shutting down a facility potentially where, we call our patients residents in nursing home lingo because it's their home. It's not an acute care facility, it's their home, it's where they live. And they want to live near their families so their families can come see them. We hire from our communities. I wish we could say we could recruit out of state and go get all the, the best nurses across the country, but we end up hiring from our communities. And so at the point where these nursing homes cease to exist in a given community, it has a very real, very palpable impact, not only on who's able to work there, but who's able to live there. So to that end, our insurance, if you will, we are for all intents and purposes self-insured. And I'm in mediation 200 times a year trying to settle cases because I know I can't try them. And we have an average settlement in long-term care of just over $200,000. I mean, y'all do that math. It's unsustainable, frankly.
So do you have any thoughts, being the lawyer on the doc side of this, on, what would have to change to make you want to go to court?
Juries
to have a fair, playing field?
Yeah.
Outside of having the data that we're trying to.
Yes.
Yeah, sure.
That's right. I will say one of our greatest points of being able to actually, seek a resolution in court is through arbitration. When we have those voluntary agreements that people can agree to, and we find it to be a very expeditious process. I know we've talked about this before in years past. I know we haven't had a lot of luck in terms of that, but we do find it to be incredibly effective. And by the way, we've gotten popped pretty good in arbitration too. I know we like to hear that it's mitigated, but you get an arbitrator who will listen to the facts, listen to your case, and we get in front of a jury, you just don't know what they're going to do.
Scott, do you want to jump in on that? Talk a little bit about your experiences?
Yeah, Scott Steiner. I'm the work at Phoebe Putney Health System in Southwest Georgia. And, the one thing, it was 2023, we were talking to our insurers coming out of Lloyd's in London, and one of the things the reinsurer got on the phone, and the head of AXA XL worldwide for their healthcare division, his first words were, "What is going on in Georgia?" And I was stunned, and they said, we're just thinking about not writing in the state because it can be so challenging. Now, they have continued. We've shown them some progress in what we're doing, but we've seen our first layer, our SIR, triple, and in just 4 years, go from 5 million to 15 million. And that is per episode, per case. That's not like, for the whole year. So every claim starts on that for us, $15 million. Of course, it wouldn't take many of those to bankrupt us. And it's always interesting to me how the plaintiff attorneys ask. They're just right. They just come right out and say, "What's your SIR?" Because they know they want to. They know they want to go up to that point, because if they've got to get into that next layer, your next layer that is insured, it's going to be a tougher case. And so it often feels like a game that we're playing, and we're at a disadvantage. And I think, just to speak to juries, we've used some jury consultants to take the temperament of the community. And Dougherty County is challenged, much like Bibb and Fulton and some of the others. And so you're quite frankly, as Dr. Jansen said, you're afraid. You're afraid to get. You think you've got a great case. I've had our general counsel say, we have got expert witnesses. We've got a witness who wrote the book on sepsis, and he believes that our care was right. But this is how the plaintiff will come into the courtroom, right? And how the juries are today. The juries are so challenged. I was reading a statistic that 80% of potential jurors, so the general public, feels like if it goes to court, there must be merit to it. If it goes to trial, there must be merit to it. 80% feel that way. They haven't heard a single piece of evidence, and that 57% would side with the individual versus a company or a business, small or large business. 57% would side with the individual. Pre-pandemic, it was 33. So I mean, we've just sort of accelerated this distrust for whatever reason, and it's a challenge. So when these big insurers, and AXA XL is one of the biggest in the world, sort of say, we're thinking about getting out of the state, we would have to, especially for our physician group, we've looked at it, we just would go bare. We would just take all the responsibility.
So Scott, if you look, say, over the last 10 or 15 years, has it just been in the last 5 that it's gotten worse? And if that's the case, what changed?
Yeah, I've been here for 6 years, so that's my scope, and I think it has certainly accelerated, and certainly when we look at our numbers, the increases, I think the plaintiff attorneys are doing a good job of finding the opportunity, and of promoting that opportunity for, it feels like a lottery win. And what I'd say is, we're not here to make it harder for patients to seek justice, right? We're talking about fairness, and I think that's what we've lost is the fairness in it. That no longer, and you don't put a price tag on someone's condition, or it's hard to do that, right? But what used to be $200,000 is $5 million, and so that I think that's the stunning part of when we talk about it, is reasonableness has left the building.
Well, I would just, say, and I said this at the last one, we want to hear from everybody in this debate, and I've talked to, a lot of folks that we deal with, on the other side of the aisle on this issue, if you will. And I don't think anybody here doesn't want fairness. But, the issue that we're having is when you have insurance companies that literally will not even offer coverage for people. Forget about what the cost has gone up, but just the ability to get coverage, and it just being, an unsustainable financial model. I think that's where we're focused, is trying to find that balance where, all Georgians can be protected, But also, we want to have all Georgians be able to get care and be able to protect their small business and the other things that we're seeing.
Well, Governor, let me just add very quickly, the challenge right now, what we're seeing is one of the issues that many of the folks in this room know is phantom damages. The defense, the attorneys are engaging in this, they'll just throw a number up there. And so once that number gets into a jury's mind, it is very difficult because that's where the beginning of the negotiation starts. And what's happening now is that I'm having to negotiate with insurance companies to allow them to increase rates without breaking the back of consumers to make sure that they stay in the marketplace. And that is the squeeze that we're facing in my agency, is allowing insurance companies to raise rates so they can stay in the market, or else we have places like what they've done in other parts of the nation where they just leave the marketplace. We've seen that in the property casualty place, and we're seeing now in medical malpractice.
Yeah, I think one of the things that we've seen too is that juries have been desensitized, Americans in general, to really large numbers, that we've lost the perception and the difference between $5 or $10 million and $100 million. They believe they have insurance, and a physician will just go to his insurance policy and figure it out, and that there is a really, really big difference between 5 and 100. Sure, Dr. Saylor.
Even on the front of economic damage, just straight up economic damage, there's administrators here. There are bills that are presented in a case that never got paid as an economic damage. There are hospital stays that are $1.4 million, and that's presented in a case as this person lost $1.4 million and had an adverse outcome. And that becomes an economic damage when there was never any economic impact. It never happened. There was no money out of pocket, nothing happened, but these are kind of things that kind of go on a pretty regular basis in the litigation. There's inequities that have developed. That's the real sad reality. So there's inequities in the system now. It's tilted towards the trial lawyers. And I heard a comment. Sometimes I feel like we're funding the billboard lawyers. With some of these awards that are being done, and I think as physicians, I think we recognize the system. We do, and I think we understand and support. We understand and support appropriate economic awards that are needed for the Georgians if they've had harm. We want people to get what they deserve, but the system's not giving that now. And in these awards, let's be honest, the patient isn't getting all the award. Trial lawyers are taking 30-40% of awards nowadays. So it's not as if we can sit here and tout that we're giving awards and it's going to a person because of the damage they suffered. That's not what's happening either.
Previous tort reform efforts have tried to address ballooning medical malpractice premiums. Do y'all think that the measures were not sufficient to prevent the crisis we're at now? Talk to me about what those of you that have been around, our prior efforts, and maybe why we're back to this point. Anybody want to jump in? Trevor, I was going to look at you.
Oh, thank you.
And the attorney.
Well, I just got back, so I'm just trying to figure out what happened. I was born here. I came back, what happened?
Sure. The state has certainly addressed tort reform in the past, or civil litigation. Why do you think we're back at this place? Were those reforms not enough to prevent kind of some of the issues that you're all facing now?
Well, that's exactly right. And when we addressed tort reform previously, and I'm going to say the scary word with the caps, the Supreme Court obviously overturned those. They found them to be unconstitutional, and I do love that we have a strong constitution in Georgia that protects a right to a jury trial. That's important. However, we have to have something in place now that we don't have any disincentive for a trial lawyer to take any case, virtually any case, and then take it to trial. No trial lawyer is afraid to go to trial. We are terrified to go to trial. And so, when you have that, you have no negotiating power on our side whatsoever. I get asked, well, how do you know how much to negotiate for a settlement? And I go, well, I ask them how much they want, and then I try to talk them into a slightly lower number. because that's where we're at. And so the point is that the plaintiffs' bar has recognized that they have all of this leverage, unchecked leverage, and that's why we're back here having this conversation. COVID didn't slow down the lawsuits. The court stopped. The lawsuits didn't. And then we ended up with a glut of 225 lawsuits just for my company in 2021, in addition to the new ones that were coming in. And so there's no fear. There's no fear there whatsoever of losing.
So, but they did help. I mean, what's it been, 20 years since the last tort reform? And the reforms that were done 20 years ago, there was some help in frivolous claims. I think there were things that the legislature did make moves that did help at that point in time. And so there was things that were done that did help. Unfortunately, what's happened has been there's been a 20-year gap, and there's been whittling away of the work that was done 20 years ago to the point now to where we're sitting where we are in here having this conversation. So I don't want to say it. There were things that were done that did make an impact at that point in time, but we're at a new point in time. And the legislature, I think legislators and our legislature has to step up and recognize the problems we're in right now and try to help us come to some resolutions.
People may not know the answer to this question, but I'm sitting here thinking, if that's the case, like what is going on in other states around us that's different on that specific side of things? I mean, do they have caps, or do they have other things that, give you a little more leverage or parity?
That's a great question. And I've got two short anecdotes about that. One is we also do business in North Carolina. North Carolina has a cap on non-economic damages. It has an exception for gross negligence, which is willful wanton conduct. The cap increases every year. And in that state, we get every case resolved. You limit the number of claims, the volume of claims goes down, because there's no longer that, I think somebody said the lottery ticket, there's no longer the lottery ticket incentive of, you know what, I could take my 200 grand now, or maybe I can go get 15, 20 million, 25 million. They don't have that. The second story is in Texas, of course, they put in a cap for med-mal cases and involving certain non-economic damages. In Texas, it was very effective. A lot of those lawyers who we saw all the time suing for medical malpractice stopped doing so in Texas. And now one of them is the #1 attorney who sues us in Georgia for nursing home cases. And he's very, very good at what he does. But the point is, if we're talking about protecting the state of Georgia, something has got to change about that. I don't know if a cap's the answer, but I certainly think there needs to be something to mitigate it.
I think we would also see in states, even where there aren't caps or where that's not feasible, there's at least some objective standard to tie non-economic damages to, or something along those lines.
Exactly right.
Are there some other folks, do y'all want to jump in? Like, what other factors have led to this crisis? Just kind of jump in if you want. We have a few minutes left. Mark?
I hate to oversimplify, but I really think when you're looking at this, I don't think anyone at this table or these tables can come up with an answer today. I really don't. And I think we really need to dive into where the stats are and where the data is so we can have an educated hit on where we're headed. But you cannot unsee or unhear. You can't unhear what you've heard. You can't unsee what you've seen. So when you're looking and that is your jury of your peers, and they hear about a suit that has just tremendous value, you can't unsee. So what you have, unfortunately, is a precedent in the state of Georgia now. And that's unfortunate. So it's gonna take some. I had a mayor I was visiting with one day, and we were talking about crime. And we were going through crime, and he's done a great job. But at the time, it was like, we're still living on the perception of the past. And so I think we're going to be dealing with this until we change that perception in the state of Georgia. So.
Thank you. I think one of the things that's important to all of us as we have this conversation is we all know those buzzwords of frivolous lawsuits or excessive litigation, but not your everyday Georgian doesn't necessarily know what that means for them. Can y'all talk a little bit, Delvecchio or Scott or some others, talk about why they should care, why everyday Georgians should pay attention to this issue?
Scott, you want to start?
Delvecchio, you started with it, is talking about access to care.
Yes.
And so that's when I think about, so every dollar, look, our goal this year is to make 3% margin. So we can fund increases, raises, and we can provide for capital. And so every dollar we have to spend on this side of the business is a dollar we don't get to use for partnering with Albany Tech and creating more for the workforce, is not investing in our community in trauma. We just opened trauma services, level 2 trauma center in Southwest Georgia. It's desperately needed, but it is one of the worst financial things to do for any organization, right? I mean, we're spending almost $20,000 a day to pay for a specialist to be on call for trauma services, right? And we only get the bill for when it's activated, and so it's to me it's access, whereas trauma, OB hospitalists. We've got our OBs here today. 15 years ago, hospitals, you didn't have OB hospitalists, but you have one bad baby case, or and all of a sudden for us, it's $1.7 million that we're spending to have an OB in the hospital, and they're just there to provide coverage. And many folks do that, but that wasn't around 15 years ago. But we've done it because of the seriousness of it. None of us want that, but this idea that our physicians and our clinicians have to be perfect. And if they're not perfect, there is someone waiting outside that's going to tee you up. So to me, the biggest worry is that it limits access to practitioners and to needed services in our community as we're shifting resources.
Yeah, I think very well said. I might only add, and it's been alluded to earlier, that no doctor I've spoken to, no health system executive that I am a colleague and partner with says that we don't want accountability. I think everybody would appreciate it because we look at it from our own perspective or that of our family members or loved ones. You want to ensure that we are continuously held accountable for delivering the best quality, the highest quality care that we can offer. At the same time, we also recognize that we operate in a context that's not with unlimited resources and tools, and so this whole thing is connected, and what we want the community to understand in this case is that we want to make sure that we are accountable for every single individual, and at the same time that we have a balance of accountability that we all share for fostering and sustaining an ecosystem that's available for everyone. And I think that's the case in the delivery of care, the allocation of resources for healthcare, but also then in this individual case around or situation around how you create a liability and litigation construct that balances those things as well. So again, unless it happens to you or you're directly connected to it, you tend to kind of gloss over it. If you're involved in it from a juror perspective, again, you're influenced by other sorts of perspectives, and you don't think about the downstream consequences because it seems like it's so far removed. It's like, it's not you, it's an insurance company. It doesn't matter, but they don't understand oftentimes, particularly when you're self-insured, that dollar then takes a dollar away from something that people need, everyone needs. And so that's what we're really seeking, and that's why I think the community at large should care about this.
Dr. Ray?
I just want to add that, I'll stay in my lane in the women's health field, but you asked about how it affects, individuals, patients, families. And I'll tell you, one of my dear friends who's an excellent obstetrician stopped doing obstetrics last year because she could not afford her malpractice insurance. She was one of the busier solo practitioners in our region. She provided excellent service and care to those patients in high quality. It was not a matter of her being sued and going through the turmoil of having to go through a lawsuit. She just could not, the juice was not worth the squeeze any longer for her to actually pay malpractice premiums and still provide obstetrical care. So it affected the lives of a lot of families when she stepped aside that. And the downstream effect was not as probably relevant or impactful as having a hospital close their labor and delivery unit. I pray that doesn't happen. And when I got to Augusta 22 years ago, I subsequently saw the next 6-8 years, 5 rural hospitals close their labor and deliveries. And then I saw what it did to my practice. And those families who were then coming 60 minutes away minimum to come and get care at the Medical College of Georgia. And while we take care of everybody, and I think we provide very high-quality care, we were using so many resources. While it wasn't a malpractice issue for us, indirectly it was. Because these hospitals were closing. If your hospital closes, the patients are sicker in that area, and then subsequently, we're taking care of a higher resource need patient that are going to be sicker. And I've spent most of my career now taking care of populations of Georgians that, I really hope that one day we get out from under this this umbrella of the maternal, care here is poor. It is a situation where we're moving, and we're changing the model to move. So the model has to change, but we're going to continue that. But I do think that if you close your labor and delivery, the amount of people that it affects is a huge piece of Georgia.
Chairman Walker.
Thank you, Kaylee. So I'm in the insurance business. I have an insurance agency, been doing it 28 years, and I think it was Scott that talked about kind of public sentiment toward being willing to sue somebody. My customers over the years seem like they're a lot quicker to want to sue somebody than they used to be. And I think he talked about the jury being more willing to side with an individual versus a company or an organization. So I don't think we can do anything about that. But what I am curious about, if you could poll your providers here, is to bring a medical malpractice lawsuit is very expensive, I think, generally, for the plaintiff. Are they seeing private equity financing of these lawsuits becoming more and more common? And is that driving some of these cases that might not be brought otherwise?
Anybody want to respond to that?
Yeah.
You see cases now with 8 expert witnesses. That didn't exist 5 years ago. How do they fund 8 expert witnesses? Because they have a corporation or a company behind them that's giving them the money in order to bring the litigation. So it makes a huge impact when someone walks into the room with 8 experts. And even here's the problem we have, and we have some academic folks here, Dr. Ray being one, and they may encounter this. Some of the expert witnesses now, they're now paid. They're literally, their job is to review cases, and they have trial attorneys and specific attorneys that reach out directly to them, and they will review that case, and they will generally try to see if they can find anything that they may call a flaw, and then they will be paid substantial sums of money to participate in the case. That's the environment that we live in and work in now.
A statistic was cited earlier about how much of the claims or the verdicts actually go to patients. And we saw something from the the U.S. Chamber of Commerce Institute of Legal Reforms. It's 53% of the awards actually go to the plaintiff, while 47, so almost half of it, goes to legal cost and fees, and a lot of that is because of these big firms that finance these cases. They're willing to go from 200,000 to a couple million, or at least take the chance that they could do that.
Thank you. We're about at time. Governor Kemp, Commissioner King, thank you both for your leadership. I hope the stories you've heard today highlight how healthcare is really impacted, and that we hope that meaningful, reasonable reforms might help level the playing field. But thank you for this opportunity.
That's great. Well, thank you, Kaylee. Great job. Let me just thank everybody for their input. Want to thank, really appreciate so many members of the General Assembly being here with us today, and really just listening. I think it shows you our interest in making sure that we're learning about the issues that you all are dealing with, where the rubber meets the road every day. We're certainly talking to the trial bar as well about things. So, we're going to continue to have an open and transparent process. But I would just make sure for our guests that are on the panel today and other people that may be listening in or here with us in the audience, this is the start of a conversation. So just because our time here today is finished doesn't mean that we don't want to continue to hear your stories and data that you have, and any other facts that you think you can get to any of the legislators that are here, Commissioner King, and certainly our team. I hope you'll continue to do that. I did just want to announce that our next roundtable and our final of 3 will be on October the 8th. So you can hold that on your calendars. We'll have more details about when, what time of day that's going to be and where, but it'll definitely be on October the 8th. So we'll keep you posted on that. And with that, we're adjourned, and thanks again. Have safe travels, everybody. Yes, sir.